Salma, please start.
Yes, sir. Good evening, everyone. A very warm welcome to today's webinar. We are delighted to have you all joined us for an insightful case discussion on subarachnoid hemorrhage. This session promises to be both educational and engaging as we delve deep into the clinical challenges, management approaches, and real world insights surrounding this critical condition. We are truly honored to have with us Dr. Raghunath Sir, Senior Intensivist, Gopalagowda Hospital and Array Hospital, Mysore. We look forward toward an enriching discussion that enhances our understanding and clinical approach to subarachnoid hemorrhage. I now invite Dr. Raghunath Sir to take us through today's case presentation. Over to you, sir.
Okay. Thank you, Dr. Salma. Today we are going to discuss about subarachnoid hemorrhage, the most important topic in critical care. And when the patient comes to ICU with the subarachnoid hemorrhage, we should know how to manage this patient effectively so that we can get a better outcome. So I'm discussing with the respect to 2023 guideline from American Heart Association, American Stroke Association. So I am now itself telling exactly the evidence where I have taken my information. As it is a case discussion, we'll go with this case. Let it be an interactive session. So any doubt you can ask in between. A 54-year-old woman developed sharp sudden headache. She never experienced such a pain in her life. She regains consciousness quickly, but she is disoriented. She brought to the EMR, emergency department. She is conscious and disoriented. Heart rate is 120 per minute, BP is 200 by 120 mmHg, saturation 100%. Her right eye is deviated laterally, low limb weakness, power is 5 by 5 in all 4 limbs. So when the patient comes to ICU like this, what is your usual next step? Anybody want to answer here? Let it be interactive so that it will be easy for me to discuss the subject. Aishwarya, what do you want to do? Dr. Shikil Pal. Okay. Whenever the patient comes like this, you can even put the answer in the chat box also. When the patient comes like this, okay, what usually we do, we take care of the airway, breathing, circulation, and try to get the ABC. Try to get the CT scan brain, non-contrast CT brain. That is usually we do. So what you suspect here, here CT taken already, CT showing the bleed. So this is a classical case of subarachnoid hemorrhage. So we can see the bleed here in the subarachnoid space, classical case of subarachnoid hemorrhage. Can you see this? Usually what happens, if intrasub hemorrhage, there is a parenchyma bleed will be like this. Okay, but that is not there. And there is no, what we expect here, we expect stroke, acute stroke. So stroke is not there, and we expect what? We expect ICH here in this patient. So ICH is also not there. It's a subarachnoid hemorrhage. There is a bleed in the subarachnoid space. So this is a classical phase of subarachnoid hemorrhage. Clinically, can we expect any sign showing the possibility of subarachnoid hemorrhage? Anybody want to answer? Clinically, very difficult actually clinically to differentiate anything. Yes, Vishnu saying CT scan brain. Good. So clinical, yeah. Okay, somebody want to answer?
Thunderclap headache.
Very good, very good. See here it is a, we can see here, whenever the patient comes with the sharp sudden headache, okay, whenever patient comes with the sharp sudden headache, so you should remember that this is the very important point here, sharp sudden headache, and she never experienced such a pain in her life. There's a very important sentence. This will tell you the possibility of subarachnoid hemorrhage, the pain she never experienced in her life. That is straight away we have to think of subarachnoid hemorrhage. So, but very difficult to differentiate. Definitely, we have to go for CT scan brain. We have done CT scan that is showing here subarachnoid hemorrhage, but we'll discuss points here. To introduction for the subarachnoid hemorrhage, this is one of the most common emergency we see in ICU. It's not very uncommon. It is very common. Aneurysmal subarachnoid hemorrhage. So there are different type of subarachnoid hemorrhage also there. One is called traumatic. Traumatic SAH is there that behave completely differently. So I'm not talking about subarachnoid hemorrhage related to traumatic. So don't will not discuss here. That can be discussed in the traumatic brain injury. Okay. Here what I'm discussing here is aneurysmal because of the bleed because of aneurysm. It is a significant global public health problem. What is this aneurysm? In the cerebral vessels, what happens here? This is cerebral vessels. Because of the weakness in the muscular layer or some tissue layer, what happens? There is an aneurysm develops in the blood vessels. That is very important. So when this aneurysm develops, whenever BP rises or because of stress, okay, it ruptures and causes bleed. That is called subarachnoid hemorrhage. Okay, so this is called aneurysmal bleed. So one of the common entity, most of the time we'll miss it. Okay, we think that it is something else, some headache is there, we miss. So you should be high vigilant to look for subarachnoid hemorrhage. Overall incidence we see 6.1 per 1 lakh person years. So this is the incidence 6.1 according to 2023 guidelines I'm talking. Okay, please remember this. A global prevalence is 8 million cases, very big number actually, 8 million cases, very high incidence in Japan. So it goes with the even the patient where the patient is actually in Japan and Finland, highest rate is there in the world actually. It is 28 to 16.6. All over the world rate is 6.1, but in Japan it is 28, more than 4 times, and 16.6 is the prevalence with respect to Japan and Finland. And sex specific prediction is more in women, more common in women. 1.3 relative risk higher compared to men. If you consider men as a 1, so it is 1.3, slightly higher side with the women. Women is the one of another is the one thing we have to think. There is possibility of SAH, and it is a very devastating condition. When the patient comes with SAH, please remember this: most of the patients will not enter into the hospital only. They will die before coming to hospital. So 13% there is a pre-hospital death is there. Pre-hospital, before the patient comes to the hospital, there a patient can die. This is 13%, and who come to the hospital, 26% will die in the up to 26% die before arriving hospital. Means 13% in the hospital, 26% before coming to hospital. So what I am telling here is the mortality is very high. Mortality is very high. So high mortality, very difficult to manage this patient. Unless you know exactly what is happening to the patient, you cannot manage subarachnoid hemorrhage effectively. We'll discuss one by one these points. There are, if you look at the, aneurysm, there are different aneurysms are there. This is a saccular aneurysm. This is one of the common aneurysm, saccular aneurysm. We can see here, there is a saccular aneurysm. This is a fusiform aneurysm. I think you can see the fusiform aneurysm. I think now you can see this fusiform aneurysm. This is a very two very common aneurysm we can see here. This is a blister aneurysm. Mycotic aneurysm we'll see in the infection, so we'll not discuss this part. Traumatic aneurysm is also we'll not discuss. We'll discuss these aneurysms, saccular aneurysm and fusiform aneurysm causing subarachnoid hemorrhage. Okay, and aneurysm may be different shapes and different types. Actually, wide neck aneurysm is there. Okay, wide neck, very wide neck aneurysm. So these all need while the managing this patient in the ICU, wide neck aneurysm. So we'll discuss this aneurysm. Okay, how do you grade SH? This is a very important aspect actually clinically. There are gradings are there. Why we need to grade? To determine the initial clinical severity and predict outcome. Okay, there are clinical scales are Hunt and Des. For the examination point of view, you should know Hunt and Des scale. This is a very important scale, clinical scale. and also another one is WFNS, World Federation of Neurological Society grade. This is recommended. Okay, you should know along with the GCS. Along with GCS, these are the scales to know the severity of subarachnoid hemorrhage. All should know this. This is the Hunt and Hess classification. So if you see here, grade 1 is asymptomatic, minimal headache and slight nuchal rigidity. This patient is having severe headache, so it is not a grade 1. Grade 2, see, it's a moderate to severe headache. This patient has a severe headache, nuchal rigidity not there, no neurological deficit other than cranial palsy. There is some eye deviation was there. If you remember that case, eye deviation is there, say it comes to grade 2. If there is no deficit and only cranial pathology is there, then it comes to grade 2. So this patient comes in grade 2. Why we should know this? To know the outcome benefit, to know the higher grade or lower grade SAH. Grade 3 is a drowsiness, confusion, mild focal deficit. Grade 4 is stupor, moderate and severe hemiparesis, possibly early desubration. Desubration will be there in grade 4. Grade 5 deep coma. Grade 5 deep coma. So grade 1, grade 2, grade 3, or we can say is the lower, but grade 4, grade 5 comes in the higher grade. So you can see here, she mentioned here, HNS grade 4 and WFNS grade 4 and 5 are the higher grade. This again we are talking about, WFNS grading. So no motor deficit, grade 1, no motor deficit, grade 2, motor deficit grade 3 with or without motor deficit, with or without motor deficit. So it is a WFNS grade 1, grade 2, grade 3, grade 4, grade 5. This Hunt and Hess and Glasgow Coma scale comparing this is 15, 13, 14, 13 to 14, 7 to 12, 3 points, 3 to 6. Just remember this. If you remember Hunt and Hess also okay, along with the GCS. See, look at the mortality here. Lower grade survival is better, 70-60%. If you go to higher grade, mortality increase, survival decreases 20%, 10%. So higher grade, lesser survival. That is the need of this grading. This is another grade for the examination, and even from the clinical point of view, you should know. Ottawa SH rule. This is called Ottawa SH rule. This is to rule out. Okay, if the patient is alert patient, more than 15-year-old age with new severe non-traumatic headache is there, maximum intensity within 1 hour, patient requires additional investigation for SAH if they meet any of the following criteria. We cannot just neglect the patient. Any non-traumatic headache is there, more than 1 hour. If age are more than 40 years, you have to go for CT brain. Non-contrast CT is the answer here. Go for CT brain. Don't neglect this patient. You can miss it. If there is a neck pain, stiffness, witness loss of consciousness, onset during exertion, thunderclap headache, limited neck flexion. So even though no deficit is there, just because of these criteria are there, we have to get the SAH, and most of the time it will be SAH will be there. This is the how to diagnose SAH actually. You can see here patient worsens with acute onset of severe headache. We can apply Ottawa SAH rule at a physician discretion. If it is less than 6 hours, more than 6 hours, we can divide. Less than 6 hours and no neurological deficit, get CT scan. So usually in ICU we will go for CT scan, but in emergency and ICU you should not miss this. This is how we should get the CT scan here. If there is no SAH, okay, then go for the further follow-up. Why there is a headache and all, we can physician follow-up. If there is a headache is there, then it comes here. If more than 6 hours or new neurological deficit is there, get CT scan done. If SAH is there, it will come here. If no SAH, here you have to do lumbar puncture. Lumbar puncture, look for xanthochromia. This is very important. If xanthochromia positive, then again go for SAH. So if the patient is having more than 6 hours of headache, okay, even though no SAH in the CT scan, we have to do LPCSF to know the xanthochromia to diagnose, SAH. This is very important. So LP have a role in diagnosis that you should know, to rule out xanthochromia, to include or exclude SAH. This is very important. If there is no xanthochromia, again send it to physician. If the SAH is there, then very important, you have to go for where is the aneurysm. If SAH is there, then there should be aneurysm. Where is the aneurysm? That should be identified by CT angiography or digital subtraction angiography. Please remember these two things. Whenever there is a SAH is suspected, do investigation like a CT angiography or digital subtraction angiography. This is the how do you evaluate. This is what I am telling here. Remember this CTA, CT angiography and CT pulmonary angiography. I'm sorry, CT angiography and distal subtraction angiography. This is the most commonly widely available and usually the commonest diagnosis that we will do after a CT scan. Okay, but for diffuse SAH, DSA is indicated to evaluate small aneurysms. Any doubtful, go for DSA, digital subtraction angiography, to know the other vascular lesions which are not appreciated in CT imaging, and it is the gold standard. So which is the gold standard to know modality evaluation of cerebrovascular anatomy and aneurysm geometry is digital subtraction angiography is a gold standard modality for the evaluation of cerebrovascular anatomy and aneurysmal geometry, can aid in the decision making, especially optimal treatment, whether the patient need coiling. So we'll discuss this part, coiling, or the patient need clipping, where we need clipping, where you need coiling, that all decided by cerebrovascular anatomy and aneurysm geometry by understanding digital subtraction angiography. So this is how we diagnose aneurysm. So with this diagnosis, we should know this. This is the usual way of managing the subarachnoid hemorrhage pre-hospital patient care continuum. Pre-hospital, come to emergency, get a CT scan here, emergency department. Acute hospitalization, we need lot of things to be done here. Post-acute care and outpatient. This is how the course of the illness. Early brain injury, how to evaluate in the phases of the care. Delayed brain injury and recovery. These are the 4 phases is there. As an intensivist point of view, you have to manage these things. Acute early brain injury and delayed brain injury, and all this health inquiry, shared making decision, education, family education, you have to do this. This is especially a comprehensive care. So we need here neurologist, okay, neurologist we need, and we need neurosurgeon also, intervention radiologist we need anesthesiologist, these are the people most commonly required, and radiology, intervention radiology and radiologist, and intensivist is the one who will take care of all this, discussing with all these people, and he will try to manage the patient condition. We'll discuss this part. So the moment you know that the patient is having SAH in the emergency, if you know this patient is coming to the, this patient is coming to your hospital, whether you can manage or not, that is very important. This come to the emergency department, SAH patient is in ED, you have to see where to send this patient. Okay, look at your hospital, whether your hospital is able to manage SAH or not. So what they're telling, there's hospital characteristics also important. Lower mortality rates in SAH patient treated in experienced cerebrovascular surgeons and neuroendovascular interventionalists. So we need specialists here. If specialists are there with large volume SAH, means more than 35 per year. If more than 35 per year means it is a large volume. So these are the hospital, they can manage SAH effectively. Small volume is less than 10 SAH per year. So these are the hospital low volume. So make sure that there should be a neurocritical care unit. So means what? If the patient is not having these specialists like a cerebrovascular surgeons, neuroendovascular interventionalists, and if they are not comfortable managing, there is no high volume, then better not to send there, or even not even low volume, better not to send there. Send to the patient where there is hospital is equipped with these facilities. Delaying transferring these facilities, there is an increase in mortality. So this is about the shifting the patient once you diagnose SAH. This is a very important point here. Next question comes to the SAH unprotected aneurysm. So patient is in emergency department means it is unprotected. Okay, what is the BP control? So anybody want to answer here? BP is 200 by 120. What is the BP goal? Who want to answer here? This is a 180 by 110, MAB by 100, MAP by more than 90, systole BP less than 160/90, or BP 120 by 70. Anybody want to answer here? Aishwarya, you want to answer? Two Aishwaryas are there. Aishwarya, yes. Shikilpal, this is very important. Who want to answer? Any message in the chat box? No. This is very important. What is the BP control? How do you manage this patient? Can anybody tell what is the BP control with respect to ischemic stroke?
Uh,
Ischemic stroke.
so for thrombo, so
185 by 110. Correct?
110, sir. Yes, sir.
Correct, no?
And post thrombolysis management 180 by 105, sir.
Very good. 181. Sir. So usually this is the BP. So before thrombolysis, acute ischemic stroke, you should remember the BP 185 by 110. Why we are maintaining high BP here? So here is the
For
brain.
cerebral perfusion.
Very good. There is a stroke is there. Okay, you want to maintain, there's a blood clot is there, you want to maintain the circulation at least by by collaterals and all after before thrombolysis. After thrombolysis also you want to maintain 180 by 110. So you want to maintain the perfusion here. Always BP comes, no, when the BP comes to with respect to brain, you should know whether it's under perfusion or means if you are not able to perfuse the brain, there will be ischemia. If you maintain high BP, there is a bleeding will be there. These are the two things: ischemia versus bleeding risk will be there. So we BP management in any stroke or bleeds is important. Can anybody tell what is the target BP for the ICH? I want other people to answer. Karthik Menon, do you want to answer here? Let it be interactive. Okay, I think Dr. Salma, you want to answer? Okay.
Sir, less than 160.
Less than 160. Okay, safest BP is 140
sir.
by 80. Do not bring below 140/80. If it is BP higher side, bring it gradually up to 160 by 90, then up to 140/80. You cannot bring below this. If you bring below this 140/80, there will be ischemic changes will be there. We don't want to maintain BP higher side BP also. It will cause bleed. So what do you expect the BP target in SAH? Anybody want to answer? Unprotected. So aneurysm is like this. So it is unprotected. Unprotected means there is no clipping done. There is no coiling done. Coiling means they will put a coil here like this. So it is unprotected. So unprotected means there is nothing has been done. So it is bleeding here. What may be the BP? Anybody want to answer? Nesar, you want to answer? Okay, this is a very difficult answer actually. So less than 160/90, very good. Shivu want to answer less than 160/90. So he has selected this answer. Very good actually. See, we cannot definitely maintain high BP because unprotected. If you maintain high BP, bleed will be there. Okay, and we cannot reduce the BP significantly because hypoperfusion to the brain causes ischemia. There is no randomized control trial to see exact BP in case of SH. So like you see in the you can see in case of ischemic stroke, ICS, there are very good trials are there, but there is no randomized control trials to exactly tell the BP. You have to bring down the BP till the patient tolerates. So imagine if the patient is not a non-hypertensive, bring up to 140 also okay. If the patient case of very non-hypertensive, up to 160/90 is the BP. So according to newer studies and observation studies, 160/90 is the BP. So answer is 160/90 is the BP. And once if BP is higher side, you should make sure that you can use the drugs like nicardipine, labetalol, esmolol, enalapril as a first line of choice. You can even use sodium nitroprusside, but usually people BP fluctuate a lot in case of this drug. Actually, careful. NTG is a immunodilator. It may increase theoretically ICP, but still many people use NTG. So you should know which drug to be used. So whenever there is a BP you want to reduce, try to use labetalol. Labetalol is the best drug actually. We can use it. So 10 to 20 mg IV over 2 minutes. 10 to 20 mg IV over 2 minutes. Maximum 300 mg can be used. Labetalol is a very nice drug in IV. It can cause some amount of bradycardia. Next come to the nicardipine. Nicardipine is a very good drug if you have nicardipine. Then comes esmolol we can use. If BP is not maintaining, if still very high after giving all these drugs, then go for the SNP after putting arterial line. So after putting arterial line, because there is a fluctuation in the BP significantly. That is the importance of the BP. Just read it about how to manage BP. This is what I am telling here. BP, nobody has studied. Increased BP definitely worse outcomes is there. Excessive BP reduction may cause cerebral perfusion. So many studies, writing group recommends BP should be, when the BP is very high, 180 by 120, ensuring strict avoidance of hypotension. Maintain mean artery 65. That's what they are telling. So maintain mean artery pressure less than, don't maintain less than 65. Closely monitoring. They are not telling exact BP how much you want to maintain. So practically it is 160/90 for the SH. If the very patient not a known case of hypertensive, still you can bring up to 140. 148 will be the safest BP in case where this study is taken. This information is extrapolated from the ICH trials. So read ICH trials. I think Dr. Mahadev has spoken a lot about ICH trials. We can read those things. There we can get the exact value. So coming to the, once you know that BP is controlled, the most important next one is why the patients are dying. That is very important. Why they are not coming to the hospital. Whenever there is a, aneurysm bleed is there, okay, there is a rebleeding is there. Rebleeding is the risk of death. Why people are not able to reach hospital, in spite of coming, they are dying because of the rebleeding. So rebleeding is the most common problem, and it's a related to life mortality actually. So BP continuously we have to maintain. Just they are telling BP is the main thing. We have to manage BP effectively, okay, by avoiding hypertension. If there is an anticoagulant, patient receiving anticoagulants, emergency anticoagulation reversal should be done. Proper reversal agents, I think it is studied. I discussed already. And if there is a routine antifibrinolytic therapy, like a what is that antifibrinolytic therapy used? I forgot. Antifibrinolytic therapy. I am not getting the name actually. That should not be useful to prevent. Don't use those drugs. Okay, antifibrinolytic therapy be used effective in trauma, but don't use here. It is not shown benefit. That is the one point I want to tell. So now coming to the BP is 160/19. What is the appropriate state? You want to put EVD, you want to put mannitol, 3% NaCl, or you want angiogram. Who want to answer here? Anybody want to answer? Revant, you want to answer? Okay, so somebody is putting in the chat box. Okay, so here the moment you know that patient is BP is controlled, you know that there is a rebleeding is the risk of death here. Rebleeding is a risk actually. We have to immediately go for urgent angiogram. That is the answer. Urgent angiogram is the answer here. Don't go for angiogram later in the morning and all. Immediately means when the patient is stabilized BP and all, go for angiogram. That will save the patient. Do not delay angiogram. Many people delay the angiogram thinking that okay, we'll do tomorrow. No, it's not like that. Patient will die if you don't do angiogram, not address the aneurysm, because aneurysm is the one which is causing bleeding and causing death. So now come to the which is the important point here, coil or clip. This is the major question here, whether to patient to consider coiling or clipping. Once you know aneurysm, there is aneurysm is there, where to do, whether the coiling can be done or you have to the clipping done or coiling should be done. This is the two options available. You have to read this trial, ISAT trial. Even though it is a 2002 study, you should know this study. 2000 patient with aneurysm judged by clinician to appropriate either modality. Most basilar aneurysm got coiled and MC aneurysm got clipped most of the time. So 1 year mortality it was 23% in coiling and 31% clipping. So coiling was much better here, no difference in bleeding, seizures study. So they found that coiling is better and it is attacked by several neurosurgeons. So this is the one study actually tried to differentiate, see whether the coiling or clipping is better. Again, because coiling is better, it has shown, so many neurosurgeons attacked this study and told. But what is exactly the answer here is, so when to do, first important, when to do the, whatever it may be, coiling or clipping, we call it as surgical or endovascular treatment. When to do it if the ruptured aneurysm should be done within 24 hours. Get angiogram within 24 hours. You should be ready for surgical or endovascular treatment. How to decide that I will discuss again. So whenever you want to try for coiling a clipping or surgical or endovascular treatment, complete obliteration of the rupture is important. Complete obliterations. Okay. If in case if you want to go for partial, so what to do for partial? So answer here, sometimes you cannot able to do complete actually because not feasible clipping or primary coiling. Then partial treatment aimed at securing the pituitary rupture site and to reduce the risk of rebleeding, and after within 1 to 3 months again reconsider the patient for the future to prevent future bleeding. Means what? Even though you want to do partial, secure it as much as possible and go again retreatment again within 1 to 3 months. So ideally what I'm telling is whenever the patient comes to the SAH, try to maintain ABC, especially BP is the main thing here. Get angiogram within 20 immediately within 24, go for coiling or clipping. That is the answer here. That's it. So which one is better? We'll discuss this part. So again, it's a bit difficult to understand here, but try to please remember this as a critical care point of view. Always, whenever comes coiling or clipping, so it all depends on the expertise. If expertise are good in that, okay, coiling, they can handle better. If the expertise are better in the clipping, they can handle it better way. So look at the expertise. Whoever expertise are comfortable, let them go ahead. And also depends on the anatomy of the aneurysm. If anatomy is not amenable for coiling, then there is no option, only clipping is the option. If anatomy is not amenable for the clipping, then coiling is the option. So that is important. Expertise is important, anatomy is important. Means anatomy means I can discuss here type of the aneurysm also, type of aneurysm. Please remember these are very important points. So in RCT conducted, 2 RCT conducted for the posterior circulation aneurysms. For the posterior circulation aneurysm, they found that coiling over clipping is better. Okay, so always it depends on these 2 points, expertise and anatomy, but in posterior circulation of stroke, coiling is better. Okay, again one more study, Brad study. You have to remember this study also, Brad study. The outcomes of posterior circulation aneurysms were significantly better in coiling than clipping for both 1 year long term. These are 2 studies you have to remember for the aneurysm point of view, ISAT trial and Brad trial. Please remember and read. So both of all of you go through these studies. So this tells better with the coiling with respect to posterior circulation. Posterior circulation will tell you how to identify posterior circulation. For patient with SAH rupture aneurysm of posterior circulation that amenable to coiling, see again they are telling amenable to coiling, go for coiling. That's it. Which is coiling or clipping is better? Timing is important rather than 2 things. First, 24 hours, within 24 hours. If coiling, when it will better, best if there is a posterior circulation stroke, coiling is better if that aneurysm is amenable. So coming again I'm stressing this point. Whenever the patient SAH rupture aneurysm is there, it should be evaluated by both endovascular and surgical expertise. Both should evaluate that one to know the relative risk and benefit of the surgical or endovascular treatment. Okay, whichever better, let them decide. But study shows if more than, some people told more than 70 years only coiling is better. No, that is not there now. Even more than 70 years, both can be considered. This is earlier many people have considered coiling. Okay, it is not so. Okay, less than 40 years of the age SAH, clipping of the rupture aneurysm might be considered the preferred mode of treatment to improve durability. Less than 40 years of the age. So age is also matters there, but if you don't worry, if you don't know, if you don't want to take too much information, leave it. But at least you should know age matters there. So another important problem here is good scale of SAH. I told good grade means grade 1, grade 2, grade 3 H&H grade from rupture aneurysm. Anterior circulation. I told posterior circulation always go for coiling. Here both primary coiling or clipping, both are options available for anterior circulation. Primary coiling is recommended to know the 1 year functional outcome. Studies have shown that 1 year survival is better if you do coiling in case of anti-circulation. If you go for long-term outcome, both options are same. Coiling or clipping, there is no difference. So what I mean to say is anti-circulation both are okay, but in examination he asked 1 year survival benefit, then coiling is better if the anti-circulation. Post-circulation, try to go for coiling. So that is the information from this. But as I mentioned, it is not easy as we think. We have to look at the type of the aneurysm. If there is a ruptured wide neck aneurysm, that's what I was mentioning here. Wide neck is there. Okay, not amenable to clipping or coiling. Endovascular treatment with stent assisted coiling or flow diverters is reasonable. Now there are stent assisted coiling, flow diverters are there. Those are reasonable for the wide neck aneurysm. If there is a ruptured and fusiform or blister aneurysm is there, flow diverters are again reasonable. With the patient having ruptured saccular aneurysm, amenable to both coiling and clipping, stent and flow diverters should not be used. So for saccular aneurysm, we are not using stent and flow diverters. They go for coiling, primary coiling or clipping. In case of fusiform, we go for flow diverters. So if it's too much information, leave it. But at least for the examination point of view, remember wide neck aneurysm matters here. Okay. So now coming to the emergency surgery. This is again important. There is a there is a SAH is there, but also ICH is also there. Big hematoma is there. Okay, what to do if there is a intracranial hemorrhage is there? What to do? Large ICH. So larger mortality benefit will get it from the clot evacuation. Go for surgery. Go for surgery and remove the clot. Okay, study has shown that. Okay, imagine if SAH deemed salvageable with a depressed level of consciousness due to large intraperitoneal hematoma, clot evacuation is the answer. So along with your clawing, clipping, so this is also important. So this is how the surgical or endovascular treatment options available. I know it's too much for you, but try to remember these things in examination point of with respect to examination as well as clinical point of view. So patient here has come from the angiogram. Okay, so anybody tell me ECG they have taken? This is the ECG. Can anybody tell me what is the problem here? You have to answer this. This is very easy. Shikilpal, can you answer this? Who want to answer this? Somebody is putting in the inferior wall MI. Very good. Shivu. Shivu is answering inferior wall MI. Very good, Dr. Shivu. And many are answering here. Inferior wall MI 2, 3. Very good. So what is happening here? You can see ST elevation is there in the 2, 3, and you can see ST elevation in the where I'm saying you're not able to see AVF 2, 3 AVF is here. So obviously ST elevation is there. So it is a MI. So I want to answer the same people who answered actually. Who answered this? Dr. Revant. So patient is come from angiogram showing ST elevation MI. What you want to do? Do you want to thrombolize? Or you want to give ecosprin? You want to give clopidogrel? Or you want to do an enoxaparin? So who want to answer this? Very difficult question. So I'll put it like this actually. Echo is done for this patient, inferior wall MI. EC is showing MI. Troponin is elevated, so 3.5. So answer is we should worry about SAH, sir. Dr. Shivu is telling it should worry about only SAH. Don't worry about heart. Your tropa is elevated. What you want to do, Dr. Shivu? Tropa is elevated here. She is having MI. Thrombolysis should be indicated. A answer. B answer. Angiogram is indicated. Probably has CAD. No urgent intervention is required. Probably does not have CAD. What is the answer here? So how many of you want to do medical management for STEMI? Very good, Revan. Stress cardiac involvement, sir. Okay. So very good. So the way you are thinking is right. Most of the people will do wrong here. What they will do here? They will give ecosprin, clopidogrel, all stuff with the enoxaparin. Okay, and people ask for angiogram. Okay, this should not be done. It is not a MI. It is not a MI. It is not cardiac heart attack. It is because of SAH. SAH causing the heart stress, as Dr. Shivu was thinking rightly, heart stress. Okay, we call it as neurocardiogenic pulmonary edema or neurocardiogenic stress, you can say, because of the brain. You know, answer here is answer. I will just show you once again, if not able to visible. Okay, you can see here ECG echo changes are very common in this patient. 20% of the SH. Many patients will have ST depression, ST elevation, TV inversion, but because that is because of the please see the answer here, because of the subendocardial ischemia, because of the contraction by necrosis, because of the tremendous catecholamic surge. See, this lady is experiencing headache. She never experienced such headache in her lifetime. That severe headache causing significant catecholamine release, causing subendocardial ischemia, causing looking like a MI. But it is not a MI. No need to do anything. Just continue with the SAH. But what is the problem here? So why you should worry? Yes, we should worry. The ECG change will be there. Most common ECG abnormality will be QT prolongation. What is important? It will tells the poor prognostic indicator for neurologic outcome. It won't be, should not be anything for that patient. But if the patient having these changes, tell attenders, patient may go bad. So what is the treatment point of view? What is the treatment for how you worried? If the patient, this patient, there is a risk of vasospasm. I'm going to discuss in vasospasm in detail. Vasospasm is again another risk for death. First risk is rebleeding, I told. Another risk of death is vasospasm. So vasospasm is set in, he may not survive. So it may indicate patient may develop vasospasm. But in case patient do neurologically better, heart becomes normal, ejection fraction 20% becoming 60%. So we should not defer any coiling and clipping. Especially anesthesiologists should know this. Never cancel this case. Anesthesiologist never cancel this case. Go for coiling and clipping. Don't postpone this case. That's how you should know the information from this. So complication of this patient will come to the again ECG showing, but Dr. Shivu is not worried. He want to continue. Many people have answered actually very good. Dr. Salma want to do coronary angiogram. Good. The thinking is right, but you should know why we should not do angiogram here. Okay. Good, Salma. Our patient is successfully coiled on the same day. Imagine Dr. Revant was the anesthesiologist. Brought to the ICU. She noted to much more lethargic now. GCS is dropped. So GCS is 15, dropped to 6/15. What may be the causes? Anybody want to answer here? Be interactive, it will be very nice. We can learn a lot with this. So GCS is dropping. So many people are answering. Very good. So rebleeding, yes. But you have already, yes, rebleeding was the risk for cause of GCS, but you already coiled. Once you coiled, aneurysm is protected now. It is called protected aneurysm. So no worries about rebleeding. There is still risk of rebleeding is there, very minimal chance. Don't worry about it. Rebleeding is the one chance, but not a correct answer here because it is coiled. Vasospasm. Karthik Menon want to answer vasospasm. Vasospasm. Everybody should remember this. Answer is not correct. Why? Always remember vasospasm developed after 4 days of aneurysm. The patient is here in first day, same day I'm talking, 4 days. Usually you see vasospasm on 7th day only. Till then you cannot see vasospasm up to 14 days. So 7th day onwards only we are able to see after 1 week. Usually it will start after 4 days. So answer here, vasospasm is thinking is right, but you should remember SH is cause vasospasm after 4 days. Usually clinically set we can see after 7 days. Do not answer first day when the patient go for GCS. Many people are answering. Next answer here is traumatic emboli. Unlikely. Traumatic emboli is unlikely. Patient is bleeding. SH patient here. So next, if you seen that CT scan, so I will answer these questions. Okay. Vasospasm I told that is not the answer. Rebleeding I told that is not the answer. Hydrocephalus. Is it possible? Yes. Whenever subarachnoid hemorrhage is there, bleed is, if you imagine this is the CT scan brain, the brainstem. Here basal cistern bleed is there, right? Subarachnoid space means bleed is in the subarachnoid space. So that can obstruct the fourth ventricle. So there will be dilatation of the lateral half of the third ventricle causing hydrocephalus. Hydrocephalus is the answer. Next answer, hyponatremia. Is it possible? Hyponatremia, is the chance is there? Anybody want to discuss about hyponatremia? Very interesting now. Hyponatremia can cause low GCS. Yes. Remember, hyponatremia is another answer. Causes hyponatremia can low GCS. Always check sodium. Very good. Always check sodium. Always check CT scan brain. So CT scan brain to rule hydrocephalus. Bleeding is the right answer, but we have done something for that. Salman Hussein, very good. She's very good. Salman. Salman want to answer SIADH. Very good answer. SIADH is the possible for the hyponatremia. So you are in the right track. So hyponatremia can cause drop in GCS. Rebleeding is one of the early complications. You should know what are the early complications: rebleeding, hyponatremia, hydrocephalus. Any other answers? Any other answers want to clinically? Just think that clinically you are there in the hospital. Seizures, very common. Seizures will bring down GCS down. So you have to remember this. These are the most common causes. Here, never answer vasospasm. They purposefully they will ask in the examination. First day, second day, never answer vasospasm. Rest you can answer. But how do you evaluate? You can evaluate too early for vasospasm. I think it's difficult for you to understand this. I will take once again. You can see here. Look at the CT scan here. Look for hydrocephalus, sodium, ABG. Why you want to do ABG here? Okay, ABG you want to do if the seizure is there, then maybe acidosis is there, or you can get even sodium in this ABG. I don't understanding why ABG. Easy, yes, easy is the best one of the answer to know the seizures. So anybody want to answer here? What is this? The done CT scan. You can see here. So here, fourth ventricle blood is there, third ventricle dilated, temporal horns also dilated. So it is a lateral ventricle dilated. So classical case of hydrocephalus. So what you want to do? Hydrocephalus, anybody want to answer here? Okay. Revant, you want to answer? Okay. Okay. What you want to do hydrocephalus for the patient? I'll take some more time actually because I want to complete this. EVD drain. Who is answering this? Salman. Very good, Dr. Salman Hussein. EVD. Somebody want to put EVD here? So put EVD here. Drain the blood. Okay. Where you want to put EVD? In the ventricle, sorry, here. You want ventricle and drain the blood. Very good. If you drain the blood, hydrocephalus. Answer is EVD is the right answer. But when to do EVD? That is the answer here. So remember 20% the risk will be the hydrocephalus. Don't worry about mild hydrocephalus. Asymptomatic does not require treatment. Symptomatic need EVD, intravascular drain. But as a critical care physician, you should know how to manage EVD. It's very important. So because EVD management is like a central in management, and pressure management is also important. If I think all our critical care people, you should know this very important point I am discussing. CSF drainage should be monitored to pressures. Allowed to drain only ICP 15-20. What is the normal ICP? 5 to 8, okay, or 5 to 10 intracranial pressure. Here we are not maintaining normal pressure with the EVD. What we are maintaining? We are maintaining ICP at higher side. If the patient is not protected, means if there is an unprotected aneurysm is there. Because if you reduce the ICP, the tamponade effect of the ICP is reduced, bleeding increases. Once there is a protected aneurysm is there, then we can keep the ICP 5 to 10. So always once it is aneurysm is protected, something done for aneurysm, maintain ICP 510. If you want to remember this. If difficult for you, leave it. Don't worry. But you should know EVD is the pressure management important. Control of ICP hydrocephalus mandatory. If there is 50% acute hydrocephalus will resolve. Late hydrocephalus may require VP shunt. Okay. VP shunt may require for late hydrocephalus. This is the EVD bundles. Please remember this EVD bundle. It is there in the 2023 guidelines. Everybody should read this EVD bundles. Okay. How to EVD setup. During EVD setup, aseptic technique, skin preparation. Location should be in the ICU or OT. EVD insertion, healthcare professional, catheter insertion size, procedure timeout, frequency of dressing, flushing. Flushing is very important, sampling, technique, EVD manipulation, exchange, nursing care. Very important here is nursing care. Nursing care education is the key thing to avoid infection. Once the patient is get infected, gone case, patient will have meningitis, very difficult to treat and very difficult to manage these patients. Whenever EVD is there, make sure patient not get infection. So it is another point here. EVD, as I mentioned here, should be performed immediately to improve the outcome. And education. Education is the key to avoid the infection. Chronic asymptomatic respiratory go for permanent CSF diversion, that is efficient, that is told. So same patient now in the ICU. What is happening here? The patient is now come to the ICU and EVD is placed, but GC is 15, very good after EVD placement, but patient saturation is dropping 78%. Somebody is doing ambu bag. So anybody want to answer here? Very interesting now. By looking at the X-ray, who want to answer here? I want more answer here. Look at the CT X-ray. Pulmonary edema. Very good. Revant is telling pulmonary edema. Any other answers? Okay, very good. Many people are answering pulmonary edema. Salman Hussein, pulmonary edema, ERDS. Very good. So here always we think that it is a ERDS or pulmonary edema. ERDS versus pulmonary edema. How to differentiate? That is a very important point as an intensivist point of view. See, if you look at here, look at the X-ray here, there is a bat wing appearance is there. Okay, that's how we can think pulmonary edema. Okay, ERDS is unlikely because it's the day one. Day one patient getting infection going for ERDS is unlikely. So you should know most of the patients have like this pulmonary edema, ERDS, always confusion will be there. But rule is in day one patient cannot get infection, at least you need 48 to 72 hours. So it is unlikely to be ERDS. So answer here is pulmonary edema. So it's always confused here. Saturation is 90. Somebody is doing ambu bag. Who want to intubate? So if you want to intubate, go for intubation. Anybody want to give elastics here because it is a pulmonary edema. How many want to give elastics now? How many want to give elastics because it's a pulmonary edema? It is not ERDS. Okay. Somebody joined now. Okay, Athira, maybe they are busy. So many people use elastics. Don't give elastics here. See, pulmonary edema, this as I mentioned here, this is the heart, this heart having stress because of the neurocardiogenic pulmonary edema. It is a neurocardiogenic pulmonary edema because of the sudden surge in the catecholaminergic causing the subendocardial ischemia, causing low LV, causing pulmonary edema. Okay, if you patient is not in a fluid overload state, intubate, ventilate, use PEEP. PEEP 10, 12, use PEEP. Don't worry about ICP. PEEP increasing ICP is very unlikely. Don't worry, increase the PEEP. Okay, don't use diuretics because hypovolemia is the biggest enemy for SAH. Hypovolemia is the biggest enemy for SAH. Never ever allow the patient go for hypovolemia. That patient will go back. So don't give elastics. Try to manage ventilator. If fluid overload is there clinically, IVC dilated, if you want to give elastics, give few doses you can give, but not like you do in cardiac patients. Counts is patient is AFib counts is 13,000. Even though 13,000, don't think of it is because of stress, SIRS, don't give, it is not ERDS, just manage like a pulmonary edema. So appropriate patient of the condition include which of the following: elastics, antibiotics, fluid management. So answer here is positive pressure ventilation. Who will answer this? So answer already I have told positive pressure ventilation required to maintain oxygenation. Even you can go for fluid management with respect to hemodynamic. Both C and D we can answer. Never ever give aminophylline infusion here. C and D is the answer here. So this is how we have to manage. Still we are the patient is in day one. Okay, now coming to the neurogenic cardiac pulmonary edema, a very important entity actually in ICU. Not at all uncommon. It's very common because of the sympathetic surge I told. Cardiac injury, even poor EF will be there, LV is down. Typically first day and second day will be there. Usually revolves after a few days. Atypical present like persisting. If the patient is having persisting, already previous fever is there, infection is there, maybe ERDS, then it should continue. Okay. If pulmonary edema, patient should resolve immediately. Better to use monitoring. Okay. Don't give elastics. I'm feeling. Try to manage with the fluid management with respect to with ultrasound guided management. Coming to the complication SAH here, one more problem. Patient is now, what is the patient is having now? Oxygenation mental status is okay. So you are intubated, mental status is okay, GC is okay. Day 8 now. Now coming to day 8. Develops fever 102. CSF is EVD is now draining. ICP 5 normal. No signs of infection. See, whenever EVD always tells no signs of infection. Output is 150 to 130. Serum osmolality 128. So somebody answered SIDH. I think Salman answered SIDH. What is your answer, Salman? You are thinking like a SIDH now? Dr. Salman Hussain, you feel it is SIDH? So answers are here. Possibility of SIDH, fluid restriction is the answer. Maybe salt wasting, aggressive fluid and salt replacement is the answer. Likely diabetes insipidus, no judgment until I get the osmolality. So answer here, please read. Who want to answer this? Anybody? Is a difficult question again. Who want to answer this? Dr. Shivu, do you want to answer? Okay, hyponatremia, sodium is low in any patient in the ICU with respect to brain, think of SIDH. Very right. Very right, SIDH is the answer. Based on the volume status of the patient, Karthik Menon. Okay, very good, Karthik. Thinking is right. But you see, in this SH patient, you already given mannitol, 3% NaCl, Lasix. Your plasma and serum osmolality will not give any clue. So this will not answer the patient condition. Plasma osmolality, serum, because already patient is losing sodium because of your mannitol or Lasix. Okay, you will not get the correct answer here. Okay, even though you get calculated osmolality, the real osmolality is something different. So here you have to go for clinically. You are right, the word used clinically. Okay, if the patient is, look at the patient fluid status and clinical status. If the patient is hypovolemic, please remember this, if the patient is hypovolemic, think of cerebral salt wasting syndrome, CSW. If the patient is euvolemic or mild hypervolemic, think of SIDH. So it is a clinical answer, very difficult to get the answer. So how do you manage this patient? If you imagine, if you give the fluid here, salt wasting, cerebral salt wasting, patient improves. In SIDH, patient worsens. If you think SIDH, you have started restricting the fluid, patient worsens, because if the patient is having cerebral salt wasting syndrome. So patient condition worsens if you do opposite of that. If it is salt wasting syndrome, you have to give fluids. So only I am telling, never allow hypovolemia in this patient. Patient may have cerebral salt wasting syndrome. So salt wasting CSW, I mean cerebral salt wasting syndrome is common than SIDH in case of SAH, but both are possibilities there. Both CSW and SIDH, both are possibilities there. Answer here is, you can see both answer, but cerebral salt wasting probably the most common cause of hyponatremia in this population. So high urine output, empiric therapy for salt wasting must be initiated. Checking osmolality is known for misinterpretations. So I will, you can read it again. So most common cause is cerebral salt wasting, but SID still possibility is there. How to manage? Look at the volume status. Euvolemia, think of SIDH. Hypovolemia, think of CSW. So give fluids whether CSW improves or not. That is how we can manage this patient. Please remember this. So hyponatremia, as I mentioned already here, cerebrals both are possible here. Only differentiating is untreated CSW may worsen. These are not useful serum and urine osmolality, and serum CSW can result from range of BNP. Hyponatremia, this is very important. Hyponatremia in SAH, fluid restriction. Many people restrict the fluids here in SAH and killed many people. So don't do that. Even you can, if the patient, you know how to treat this patient. If symptomatic, as you see any patient with hyponatremia, 3% NaCl if the patient is symptomatic. Okay. So this is another one thing. Fludrocortisone is useful. Please remember this. Fludrocortisone is useful in these patients. Again, complication SAH again, who want to answer here? After selection of salt and water deficit, you know, say patient is lethargic, but next day GCS is 8. Means lethargic, GCS is 8. Repeat CT shows EVD in place, no hydrocephalus. Which of the answer? So patient is, remember now the patient is in day 8. So possibility of what? What you thinking? Anybody want to answer here? Who want to answer here? What is the possibility? GCS is dropping in the day 8. Vasospasm, very good answer. Vasospasm, when the GCS drops in the later part of the illness, vasospasm. So people give fluids, not enough to push the BP, angiogram is required, dobutamine people use. So answer is very difficult to answer this vasospasm. So once the vasospasm set in, you have to manage effectively. I think first you have to prevent this vasospasm. So vasospasm prevention is a very important. How to prevent, I will discuss again. Here this patient probably have vasospasm. The right answer is vasospasm. You have to give fluids. Again, fluid is the matter there. You can bring the BP up. Okay, dobutamine to increase the cardiac index, improve the servo perfusions. People use angiogram. You know, last option you can put angiogram, which is act as a diagnostic as well as therapeutic also. Okay, hyperdynamic therapy. Something called hyperdynamic therapy is there. Hyperdynamic therapy or triple S therapy, 3S therapy, something called 3S therapy or triple S therapy. Hyperdynamic therapy is there. Remember this. People have given a lot of fluids to increase the hemodilution, to cause hypervolemia, to cause hypertension. So here hemodilution will not improve the patient. Never ever do that. Hypertension, yes, it will be helpful. Hypervolemia also not helpful. Okay. So here we have to give fluids if the patient dehydrated, and BP, increasing BP is the answer here. So I will tell you how to manage this patient. 20 to 30% will have the, you know, vasospasm, leading cause of death. Depending on the basal system, you know, Fisher grade 3. I didn't answer Fisher grade. Another grading is there in CT grading with respect to SAH. In case of CT brain, with respect to CT brain, all of you read this and learn this. Fisher grading, grade 1, 2, 3, 4. So okay, Fisher grading is very important grading with respect to CT scan brain. Read this. I forgot to mention that. Vasospasm occurs as a result of spasmodic effect of the blood. Any size of vessel can spasm. It is not like a small vessel, big vessel. Any vessel can spasm, small arterioles to big vessel. So spasm never start before 3 days. As I told, after 4 days only. So peak incidence 7 to 10 days. So when these 7 to 10 days, we can able to manage, identify this patient. Symptomatic spasm lasts from days to weeks. Many patients will die because of vasospasm. All those have asymptomatic vasospasm will be there, but some patient will become symptomatic. How to diagnose these conditions? By clinical GCS. Okay. Most important thing is transcranial Doppler. You have to do transcranial Doppler. Single transcranial Doppler is not helpful. Multiple, continuous means recurrent, repeated transcranial Doppler, daily transcranial Doppler we can see to know the vasospasm in the blood vessels, whether the speed of the blood is increasing or not. If the speed is increasing means vasospasm is setting in. So that is how we should monitor the vasospasm. So try to reverse it the hypodermic therapy. I'll tell you how to do that. So how to identify this? Answer here is what is that? Transcranial Doppler. How to identify? SAH, suspected vasospasm, limited neurologic examination, CTA, CT perfusion is best to know the vasospasm or delayed cerebral ischemia. This is also called very important terminology, delayed cerebral ischemia. In patient with SAH, transcranial Doppler ultrasound monitoring is the reasonable to detect vasospasm to predict TSI. As I told, don't do one time, do every day. High grade SAH, EEG is also important to predict DCI. High grade SAH, monitoring brain tissue oxygenation, lactate pyruvate ratio, glutamate may be considered to predict DSI. How to prevent? Prevention is nimodipine. Nimodipine should be given. How you give nimodipine? Answer is 60 mg. It is not BD or TID dose. It is a 4th hourly. See, nimodipine 4th hourly on the day of admission. Any patient SAH, start nimodipine 4th hourly. So that is the answer here. So nimodipine should be started. Good evidence is there. Nimodipine is the answer. Day 1 you should start. Okay. Hyperdynamic therapy, as I mentioned here, don't go for triple S therapy. Don't go for triple S therapy. As I mentioned, slightly we can maintain higher BP. Just this is the update thing I'll discuss. Nimodipine should be started enteral to prevention. U volume is the most important to prevent DCI. Symptom vasospasm, BP should be elevated to reduce the progression severe of DCI. This much we can do. Nothing else, not more than this actually to prevent this. Severe vasospasm is there. We can go for intra-arterial vasodilators. I will discuss that part to reverse the vasospasm. In case of severe vasospasm, cerebral angioplasty is the final answer. Okay, final answer is cerebral angioplasty. So these are the intra-arterial vasodilators, papaverine and verapamil, short-acting. Angioplasty, very risky, can be done in the larger vessels. If you remember this, it is okay. Not recommended. This also you should know. Many people use statin therapy is not recommended. Routine magnesium is not recommended. Prophylactic hemodynamic augmentation is also not recommended. No, it is not recommended. So this is how to manage SAH here. So okay, class 1 oral nifedipine, okay, and regular neurologic examination you should know for the management of the vasospasm. It is there in the 2020-23 guidelines. You can go through this, and if go for TCD monitoring daily, class 2 year recommendation, and invasive multimodal neuro monitoring, TCD monitoring, and EEG also. Avoid prophylactic hemodynamic augmentations, not required now. If the worsening neurological is there, address the examination confounder, like maintain the high BP, ensure euvolemia. You can go for CT angiography. Okay, endovascular circular therapy. If you are not able to, if the patient is not improving with this, go for endovascular therapy or even angioplasty. If the patient is still worsening, then we have to explain the patient conditions. So this is how we should manage. Seizures will be there. Another important point. Another 2 minutes or 5 minutes I will take. Seizures is the another answer. So if the patient is having fluctuating neurologic examination, depressed mental status, ruptured MC aneurysm, high grade SAH, ICH, hydrocephalus, cardiac infarction, or EEG monitoring is reasonable to detect seizures. If these things are there, you can go for prophylactic. Earlier we have never used the prophylactic anti-epileptic drugs. If the high risk seizures is there, these are the high risk seizures. You can go for prophylactic anti-seizure medications. If the patient is having seizure, if these high risk is not there, don't use your anti-epileptics. Don't use phenytoin. Phenytoin is showing mortality, higher mortality. Okay. Prior epilepsy who present with the seizure, treatment is only 7 days. More than 7 days is not required. Okay. Without prior epilepsy who present with seizures, beyond 7 days not effective. Only do 7 days treatment. More than 7 days increase the risk actually. So recommendation, acute recovery, then you should think of cognitive, think about physical, cognitive behavior, quality of life. Rehab therapy is very important. Depression is there. Many people use fluoxetine, but fluoxetine doesn't do much helpful actually. So more of rehab therapy is required. So I mentioned fluoxetine. Thank you for this. So any question with respect to this, I'm ready to answer. Anywhere it was difficult to understand also, I repeat. Dr. Aishwarya, two Aishwarya were there. Dr. Aishwarya, you want to discuss, tell anything? Dr. Evant, any questions in this? Dr. Shikil Pal. Good actually discussion, interaction actually. Thank you for excellent teaching, sir. Okay, thank you. How to differentiate sepsis-induced cardiac dysfunction and neurogenic cardiac dysfunction? Okay, what is the question here? Sepsis-induced cardiac dysfunction. Okay, very good actually. Neurogenic cardiac pulmonary edema seen in day 1 and day 2. As I mentioned, day 1 to day 2, not more than usually day 3, day 4, because that where cataclysmal surge is very high. Sepsis will set in after 48 hours. And sepsis after 48 hours to cause cardiac dysfunction, it takes many more days. So it's a late. And how to differentiate clinically? Here what happens? Global hyperkinesia will be there. In neurogenic cardiac pulmonary edema. Sepsis also global hypokinesia, but RA, right ventricular dysfunction, is very important in case of sepsis cardiomyopathy. I will discuss that part. now you should know one first day, 2 days, it should not be sepsis, it should be neurogenic. Any more question? Good, Salman. Any more questions? Anything else you
Sir, I
want?
want to know about the neurogenic cardiopulmonary edema. We should use Lasix or not at all, or we should only give a bolus dose depending on the situation.
No, no.
How
This,
should we?
yeah, I will answer this fluid. No, when come to the fluid management, I think one more doctor was asking question how to give fluid when there is a. I think I didn't. I was not answering his answered his question actually. I think he's texted in the group in the web actually. See, fluid management. I think many people are difficult to understand. I will answer this question. I'll take a separate class for this. See, fluid. What I'm telling is, it is not like you should not give acids. It's not like you should restrict fluids. It depends on the patient. Okay, it depends on the patient. Imagine if the patient is okay. Okay, you look at the IVC. IVC is completely dilated. Okay, not collapsing. Okay, or dilated, not collapsing. Okay, if it is more than 50% collapsing, then we can give fluids. If it is not at all collapsing and dilated, then I think you are loaded with the fluids. Okay, and RARV dilated. Okay, then you can use. Okay, don't give fluids there. You have to remove the fluids if the patient is loaded. And in this patient, your patient is not loaded here. Same fluid is there in his body. You are not added, or no more fluid is extra is there. It is the redistribution causing pulmonary edema. What you can do, this patient best managed with the PEEP. As I mentioned already, heart-lung interaction. If you give PEEP, it reduces the preload, it reduces the afterload, and pulmonary edema resolves. Okay, if you want to give Lasix, you can give. I'm not telling not to give. 1 or 2 doses can be given. So it is the how if the patient is already fluid overload, examine renal failure, fluid overload, you want to give Lasix. Cardiogenic pulmonary edema, fluid overload, give Lasix. I'm not telling not to remove fluid. In this patient is not having more fluid. It is just a redistributed pulmonary edema. How to manage this? With the positive pressure ventilation, which reduce the preload, afterload, and manage the fluid management. That is easy. I think I answered your question.
Yes, sir. And the range of the PEEP, how much should we keep it?
So PEEP, PEEP with respect to ICP, there is a lot of controversies there. Many people, you don't use PEEP because ICP increases and all. Nothing like that. Okay, you can go up to 16. I can say experimental studies up to 16 you can see, but nobody use that much PEEP. 10, 12, 14, you can go easily. You can go for that much PEEP.
Thank you, sir.
Okay, if no more question, thank you all for attending this. Okay, I think most of the people are attending, many more still not able to attend. Okay, I think there will be a record session will be there. Thank you. I'm closing this now. Okay, thank you. Thank you, Revan. Thank you.